not exactly pitfalls in the eco-assessment of LV systolic function. I like to highlight only on the determination of ejection fraction. So only part of the total comprehensive assessment of LV systolic function. And I will just highlight on the common things what we are currently doing in Bangladesh. So the common options are, as we know, M-mode, that is Ticho's method, Simpson's biplane method, 3D volumetric method, eyeballing, and artificial intelligence-based methods. Just here are the methods. I will highlight one by one. This is the much neglected and virtually denied method nowadays. It is the Ticho's method, but unfortunately, we are continuously doing this. This method is based on the assumption that heart is a geometric structure, especially the left ventricle. And this is true in case of a healthy person. And if the heart is contracting in a nice way, symmetrically, in that case, this method is not bad. And you know that just it considers the left ventricular section at the level of the mitral tip of the mitral valve. So if you are dealing with a normal heart, this is not a bad one. And also in some abnormal heart, this is not bad. Like the patient with dilated cardiomyopathy, and if it is ischemic, non-ischemic dilated cardiomyopathy, that is idiopathic, in that case, we think that the heart is going to contract symmetrically, though poorly, and still in these cases, this method is not a bad one, and this correlates well with the advanced methods. But if your left ventricle is like this one, you are seeing that the anterior septum of the left ventricle is rather dyskinetic, bulging outwards during systole and having no systolic contraction. And the same is seen on the left side. And if you are applying this Ticho's method, in this particular case, there will be wrong impression of the ejection fraction. And in these cases, Simpson's method may be a very good solution because it virtually avoids geometric assumption. It tries to divide the whole left ventricle into a number of maybe 20 discs, and whenever the discs, volume of the discs are summated together, you will get a more comprehensive left ventricular volume and ultimately ejection fraction. I like to just highlight these three images. The normal heart is like the left one, like the banana heart. You know that the collar mocha English is banana heart or the banana blossom as well. And in the middle, this is the jackfruit, though the heart is not like this one. But if you are fortunately dealing with a patient with idiopathic dilated cardiomyopathy, the heart or the left ventricle may look like this. And in these cases, geometric assumption is possible. But on the right side, this is the monkey jack, that is the dewa. And in that case, though it is the cousin of jackfruit, but the symmetry is lost. And unhealthy left ventricle may be like that. And in these cases, geometric assumption is not possible. Simpson's biplane method is the currently recommended and the most popular method for day-to-day use. And it gives excellent result regarding the determined ejection fraction if the endocardial border delineation is a very good one. And you are seeing that the left ventricular volume in end diastole, end systole, all are taken into consideration, usually in two planes, apical 4-chamber view and apical 2-chamber views. So the pitfall is that if the left ventricle has a predominant problem in the septum or in the posterior wall, in that case, because of the lack of consideration of the apical long axis view in the routine biplane determination of Simpson's method, we can overestimate or underestimate the Simpson's ejection fraction. So Simpson's is not always the. So sometimes in practical life, the issue is whether I am dealing with Telly Samad or Madhuri Dixit or Adnan Sami. Sometimes it matters so much so that even the latest generation machine, whatever may be the vendor, we may be sometimes puzzled what exactly the left ventricular ejection fraction is. So whenever I am dealing with echocardiography, I like to appreciate those patients with Telly Samad or Madhuri Dixit. Always look for left ventricular ejection fraction if there is mismatch. Just consider this 75-year-old man with old myocardial infarction, and here you are seeing that the predominant pathology in the septum, and the septum is rather dyskinetic, and when the ejection fraction by the Ticoi's method was considered, this came to 47%. Why? Because if you are looking at the basal part of the left ventricle, it is contracting well. So whenever the M mode is passing through this area, the contractility is well good, and because of this the ejection fraction is like 47%. Unfortunately, many echocardiographers in Bangladesh right now just are dealing with this type of ejection fraction, and they are confidently writing that the ejection fraction is 47%. But wherever the Simpson method was applied, the ejection fraction just fall below 30%, that is 29%. So always try to correlate with everything, otherwise there will be false ejection fraction. Now another important aspect is utilization of artificial intelligence. You know that even the artificial intelligence is being used in the Russia-Ukraine war. Just yesterday I was reading an article regarding this. And artificial intelligence we cannot avoid nowadays, and most of the good quality echocardiography machines have got the provision of artificial intelligence, and I will show you how we can do ejection fraction by means of application of artificial intelligence. But the problem is that if the endocardial border delineation is not a good one, in that case, again, the artificial intelligence-based ejection fraction may not be a good one. In this particular case, the endocardial border delineation is a good one, and here the ejection fraction by artificial intelligence is 44%. Is artificial intelligence dependent LVEF reliable? Yes. If you go through some current papers, there is excellent correlation between the artificial intelligence-based ejection fraction and MRI-based ejection fraction. So we can rely on artificial intelligence-based ejection fraction provided that the 2D echo image is a very good one and the endocardial border delineation is a very good one, and you are also intelligent one to correlate everything. Then it is reliable, and certainly it will save your time, and sometimes there may be more confident determination of ejection fraction. But certainly AI-based ejection fraction has got drawbacks. Like this one, if you look at the images, whenever the artificial intelligence button was applied, falsely the whole heart, that is the left and right ventricle, was taken together as the left ventricle. So here the computer has done a very dangerous mistake. And if you are doing artificial intelligence by this means without just correcting this, there will be a false artificial intelligence-based ejection fraction. Nothing is perfect if window is poor. Like this one, look at this, the endocardial border delineation is 1. And what should I do? Should I do 2D? Should I do Simpson's method? Because endocardial border delineation is virtually impossible with this window. So all the books are silent, all the guidelines are rather silent. They are going to just tactfully bypassing this issue. They are fond of just Simpson-based ejection fraction or 3D-based ejection fraction. But what to do with these things, they are not dealing with much. Now, the issue of LVEF by eyeballing. We do not like to appreciate this, but this is like the amiodarone. We do not like this drug, but we cannot avoid this. When the endocardial border delineation is a very bad one, or the window is very poor, in that case, we have nothing but we have to rely on eyeballing. And just believe these, a very good number of papers are available in which eyeballing based ejection fraction correlated well with cardiac MRI based or even cardiac catheterization based ejection fraction. But the problem is that for the excellent correlation between these two, you have to train your eyes more and more, and you have to gain a high experience. And only in that case, you have to do a very good eyeballing. So don't neglect eyeballing. What is the solution with this patient? The endocardial border delineation and the window is so poor that I have to virtually rely on the just my common sense that as the visible left ventricle is contracting well, going inward, so most probably the ejection fraction is a good one. But if you ask me what is the number, sorry, I cannot mention any number. With this, I like to conclude my session. Thank you all.
Thank you, Dr. Monor Islam.